Thank you, everyone. This is like the last session in the regular competition, I would say. After this session, we have a short break, and then we have our student session. And I'm gonna miss it, but I advise you to all stay and listen to them. We have two speakers in this hour-long session. The first speaker is a really great guy, an amazing human being. He's just incredible. He's also my boss. No, he barely needs introduction. It's Michael Colligan. He's executive director from Orem PSO, and he's going to explain why you all have to join. Thank you, Michael.
Luke, that was probably the best, it certainly was the best introduction I've ever had. I'll have to have my kids watch this. They won't believe you by far. So a big thank you to everyone who's involved in bringing me here today, everyone with the Sanibel meeting, and I'm glad to see people in the seats because it seems like a lot of people had a late night last night. I was not one of them, so take that to the bank. My disclosure for this talk is also my title. So I'm going to talk about patient safety organizations. I work for the Orem Patient Safety Organization. I will tell you truthfully, I think we do a great job specializing in the cardiac surgery space and the ECMO space. The things that I talk about technically can be done by any patient safety organization, and there's probably about 50 listed with the US Department of Health and Human Services. One caveat is that everything I talk about is going to be legally related to how things operate in the US, and I can't comment on how things operate in other parts of the world. I know we have a worldwide audience. I will talk there'll be a few things that I'll bring up in this talk that you're gonna think, oh, that's 1 in a million, that'll never happen to me. But I would say to you, these things do happen. They are not frequent, but they probably are at least as frequent as you might think of an oxygenator failure. Maybe not an ECMO oxygenator failure, that's something you plan on, but one that might happen during bypass. That's a rare event, but you don't put it out of the realm of possibility, and that's the same thing we'll see here. So I named this talk the multi-tool for success. So we're used to using a lot of tools. If I had a Phillips head screwdriver, I'm going to use that to back out or advance a Phillips head screw. I'm not going to use that to pry something open, to cut the tape on a packaging box. At least I shouldn't. It's not going to be well used in that way. But there are tools that are designed and built to be multi-tools. You've got your Swiss Army knife, you've got your Leatherman. Those things are meant to have multi-purposes. And that's what patient safety organizations are. They're built to have many purposes. So we're going to try and touch on a lot of them today. So let's talk about simulation. Are you doing simulation, whether it's in the wet lab, training staff, doing them annually, maybe not with students, but this is one of my colleagues, Rob, and he's doing some introduction here to eventual wet lab and simulation training. But I want you to ask yourself, assuming you're doing some of those, and I'm encouraging everyone to be doing those and happy to see those people that do them, what if someone requested records of that training? What if they asked you and or everyone else who was present for test scores, pre-test, post-test, performance times, or any video recordings that you or anyone else who was present at that day took, or photographs of that event? How comfortable would you feel handing that over? Number one, just knowing that it was asked for, but number two, you don't know what clinical cases this person's been involved in recently. Well, a PSO can fill that protection gap. So if you have a patient safety organization, you can conduct those simulations inside what's called your patient safety evaluation system. And that means that pretty much everything other than the fact that it happened, that the training was conducted, can be considered patient safety work product. And inside a PSO, patient safety work product is confidential and privileged. It's inadmissible in court. So you can have everything in there, your recordings, your scores, your performance times, et cetera, et cetera. That can all be patient safety work product. Let me ask about benchmarking. I know a lot of facilities we've had benchmarking in cardiac surgery for a long time. And benchmarking is something I think that's picking up with a lot of the different systems out there wanting to do benchmarking for their healthcare systems or their equipment. They want to have their equipment have a good benchmark. So are you benchmarking maybe locally within your team, across the country, across state lines? A lot of places, we heard a lot this week about AKI. And if you want to know the AKI rate of different clinicians or different providers on your team, what if someone requested comparative performance metrics from a clinician? What if they asked you as a chief perfusionist or you as a hospital administrator for relative transfusion rates of different providers, whether that's a perfusionist or a physician? What if they asked for comparative data on the DO2 of different perfusionists over the course of a couple of cases or their career, or the AKI rates that are linked with different individuals? Well, PSOs can fill that comparison gap. So one of my good friends, Peggy Binzer, she works at the Alliance for Quality Improvement in Patient Safety, wrote this white paper for Compliance Today, using PSO protections to enhance the effectiveness of clinical registries. And the PSOs legally allow you to do benchmarking inside the PSO. So your facility, your groups, your individual providers, all those comparisons can be protected as patient safety work product, and you're not worried about, number one, any unclear regulation at your state or local level, but any differences between states. All these protections that PSOs offer, since they were created by the Patient Safety and Quality Improvement Act of 2005, provide protections across the country that are uniform, and you don't have to worry about that. Here's a big one. I love that OnlyFans only bypass. What was that talk earlier that we saw that was had so many of those great posts on there? Okay, this is a little bit different, but social media is out there and really a big part of what we're seeing. So when suckers are turned off after half-dose protamine, they provide a picture of what happened at their facility. Now, I've blacked out the people participating here, but I've got two brief examples, and this only took me a few minutes to do. Now, if you were a plaintiff's attorney and your patient had some type of injury related to cardiac surgery, you could easily search and find people in that area who are listed with the state, maybe licensed as perfusionists, and it wouldn't take you long to see what they had posted on social media. It's not going to be instant, okay? But with a very little bit of detective work, you could track this down. Let me plug this back in. And here's another one. How do you handle bypass in a patient with known heparin sensitivity from prior exposure to porcine heparin and therefore potential hit? Now, this one seems less problematic, but not necessarily. What if a post that was made on social media was used as evidence that either you lack clinical competence, you didn't have good policies and procedures at your facility, or you had no policies and procedures at your facility? In that case, the question about HIT. What if a patient that was unrelated to a patient that was injured asked for that as a reference? So somebody receives an injury that happened at your facility. It's totally random. Nothing could have been done to prevent it, but they're considering lawsuit and their plaintiff's attorney sees that post. All of a sudden, they're going to be digging deep to see if that's connected to their case. Okay, was my patient the patient you're talking about? It's not even a question you want to have. So PSOs can allow you to fill that information gap. You can create basically an information exchange inside a PSO, and you can allow information like clinical experiences to be shared, policies, bad outcomes, lessons learned, et cetera. And importantly, even the request for information can be considered patient safety work product. So you don't have to post on social media, hey, we don't have a policy for HIT. Does anyone have one that we can use? Instead, you can do that inside the PSO or through the PSO so that even the request for information is protected. Okay, here's one that's this is more into my wheelhouse and my area of expertise. Do you go back and do root cause analysis of accidents or sentinel events that happen at your facility, or maybe even near miss? Here's two. I want to make sure that we play these in. So in this case, this was a case where they had intermittent retrograde air entering the aortic root, the aortic root through the aortic root vent. So the perplexing thing to them locally was that this was happening only intermittently. It wasn't a reverse roller head because the root vent was working most of the time, but intermittently would say, okay, the surgeon would say, okay, now there's air coming in. It's not sucking the blood out. This case here, we helped understand what was happening. This facility had retrograde gas embolism through their circuit just prior to initiation of bypass and had a hard time identifying what the causative factors were here. Okay, let's advance. Okay, this video has been on YouTube for more than 50 or at least 15 years. I don't know if anyone's seen this before. I'm surprised that it doesn't have that many views. I was told, and I'm not stating this as fact, but I was told by somebody who knew the producers of this video that this video was an attempt to demonstrate what had happened. They were making an effort to reproduce something that had happened during one of their clinical cases. So I'll let you, this is 33 seconds, and there is audio. Listen for the alarm.
100. Start to check a little bit. Oh, yeah. Fuck. Oh, no. Oh.
You should have seen that from up here.
Yeah, I heard it.
So, okay. Well, the question I think is, what if you don't want to know the answer? And I feel, because I work in this area, unfortunately, sometimes something will happen. It's kind of a fluke, one-off, one in a million thing that people feel, and they don't look into it because they may or may not want to know what the answer is. They kind of say, oh, it was, microclots, or they'll give some explanation that doesn't really jive with what reality is. But the important point is, it's important to understand these events so that you can prevent them in your practice, and also to transfer that information over to other facilities so that they can prevent them in their practice. So this part of this problem that I see is, what if something happened and you were called to testify? If you don't know what happened, then you're okay. And I think that leads some people, or at least you have plausible deniability. I would never lie under oath, and I think that a lot of people come to a problem point where they realize something has happened, but they don't want to know what it was. So what if you have to ask yourselves, what if the results of a root cause analysis pointed to you or pointed to one of your staff members? But even if that was something where you had never heard of this event happening before, or you had never been educated about it, you couldn't find any case reports on it, would you want to know what happened? And the point is, with a PSO, it can fill that confidence gap. So really the kind of the highlight and the big picture thing with PSOs is that any deliberations or analysis you conduct can be done inside your patient safety evaluation system, so that the understandings you gain are patient safety work product. So certainly you would want to consult with an attorney, but let's say you have something terrible happen in the OR, right? You are actually not sure what happened. The second you walk out of that OR, you start an analysis inside your patient safety evaluation system. That way, all the learning that you get, all the understandings and the knowledge that come to you through that investigation are part of your patient safety evaluation system. They're patient safety work product. Now you don't have to go and lie under oath. You can just say, when you're asked, if you were deposed, you could say something to the effects of, we conducted analysis inside our patient safety organization, and I can't discuss what we found because that's patient safety work product. That allows you to gain that information, that allows that information to go to other facilities, that allows that information to improve patient care without worrying about self-incrimination. So you can eliminate that risk of you don't really want to know what happened. Have you ever seen some type of fault or malfunction and wondered if others are experiencing the same thing? So we actually received reports, and as Luke said, he worked with us. He's an analyst and helps investigate these reports that we get. And we had 2 reports, both involved patient harm to varying degrees and of these cannulas failing. That came in a very short period of time, very short window. And it caused us to go back, do a deep investigation of these reports, and compare that to data that we've pulled from the MAUDE database. And Luke was I would say, primary author, but we don't put authors on our reports. But Luke really helped pull together the analysis that we did, and we sent out a special report to AMSEC, sent out a special report to ELSO. This is a VV cannula that's typically used for ECMO, about the failures that we were identifying. And specifically, we were able to pick up what I'm calling kind of prodromal symptoms. So these would be early warning signs of that this cannula was failing that a lot of people appeared to miss in their clinical practice. And in fact, I talked about this very briefly at the Winter Park Perfusion meeting. And after that meeting, a surgeon came up to me and said, you got to find a way to distribute this information more widely. We had a patient on ECMO. They had all the exact criteria that you identified in your early warnings, and we got air in the ECMO circuit, couldn't find a cause, changed it out, got air in the ECMO circuit, couldn't find a cause, changed it out. Third time they changed out the ECMO circuit, they discovered that this was the causative factor. And it was very much occult. It was a small hole right in the same location. Obviously, these are 2 different cannulas. I don't want to confuse anyone here. But have things like this ever happened to you and you're like, this can't be that, I've got this 1 in a million failure that's happened to me twice. So what if you could receive timely notifications when there was an uptick in specific device failures or defect types? So we as a PSO, we're not restricted by any FDA requirements for reporting. So we can send out reports whenever our spidey senses go up. So we can send reports out much earlier than manufacturers might want us to, but we can also wait until we really understand events to send those out. We're not forced to send out a report like a manufacturer might be and say, well, we don't really know what's going on, but we've seen X, Y, Z. So a PSO can fill that gap. We can receive and distribute information about product issues before a specific threshold is reached. And that information that comes in and goes out, just like I said before, can be patient safety work product. In this case of this cannula, we actually de-identified that and took that information out, making that report public so that everyone could benefit from it. So that's not patient safety work product when we release something like that through AMSEC. So I have probably 8 minutes left, and I'm just gonna let this finish up here. So that's what a PSO can do. It's the multi-tool for success. You can fill that protection gap when you're doing simulations. You can fill that comparison gap when you're doing benchmarkings. You can fill that information gap when you want to ask about policies or procedures or what other people are seeing clinically in their practice. You can fill that confidence gap to investigate events that happen at your facility and take information from understandings that are reached at other facilities without the worry that that will incriminate you. And finally, you can fill the distribution gap so that you can get timely information before you have to have a catastrophic event or before things are very late. In the case of those cannulas, the things that we identified, and you're welcome to go read the report through AMSEC, are not, they wouldn't cause a recall. They're not manufacturer defects, and they're also not user errors, but it's a unique combination of situations that lead to that. So thank you very much. I'll be happy to entertain any questions.
Thank you so much, Michael. As always, a good presentation, and I don't say that because you're the boss, but any questions? Yes. Please.
Yes, very interesting. So how does a person develop the confidence that there's no discretion, everything is safe, everything you present? When I look at the legal world today and what's going on in the political realm and the social media, how do you guarantee that?
So there's a couple of things that I think go into that. Number one are the legal protections. So you can go back and look at the law, but to be a patient safety organization, we have to become listed with the U.S. Department of Health and Human Services. So we've gone through a self-attestation process to get listed that way. In addition to that, there are fines for violating that are greater than HIPAA violations. So there are legal protections. But I think the most important protection is that the information that's out there, let me back up and I didn't say that right way. The legal precedent is this, that if confidentiality or privilege is accidentally breached, that information, the other one still remains attached. So let's use an example. I write a report to you and I say, hey, I did this analysis on this event that happened at your hospital. Here's what we think happened. And it's really damning, right? Looks terrible for you guys. And your hospital is being sued. And somehow that report that I sent to you, you forwarded it and you accidentally send it to the plaintiff's attorney. It is still inadmissible. You accidentally breached the confidentiality, but the privilege remains attached. So even though they have that in their hands, they cannot use it either directly, or if they tried to make that argument, they would have to show that they came to the conclusions that are in that report somehow independently. And which is a very high, it's a very high wall to climb, I guess is a good way to put it. Yeah.
Thank you.
Mm-hmm. I will say briefly, as we have other questions coming up, I've noticed that people become much more confident in making reports when they see reports. So every quarter for our members, we're putting out 15 to 25 Sentinel events that have happened through the country, and they're reading those, and they know that when they submit a report, it's a drop of water going into the ocean because the data is already the amount of reports are already so large.
Good job, Mike.
Thanks.
So a question about the reports that you generate. So obviously we know that Luke's a good perfusionist and, is well qualified to help analyze these scenarios. But tell me about kind of, not vetting, but tell me about kind of what determines that your report is more credible than maybe what they could come up with themselves? Does it go through a panel? Is it just one person? Can you talk a little bit more about that?
Sure. So we published our methodology in JECT, I believe, in 2021. And so I'm not saying that it's perfect, but we feel like it's a good system. We take the report, we use some tools that the government has through AHRQ to help prompt us to think in certain ways. And our reports always have to reach consensus by 2 independent analysts before we finalize them. And then sometimes we go back and amend reports. And in fact, I want to be careful what I say. We had one report many years ago when we first started that we came to a certain conclusion. And the good thing is we can pull in outside experts and we can deputize them using the Patient Safety and Quality Improvement Act. And they can be bound by law and still help us out in small cases. We had an engineer look at a piece of equipment and they said, oh, XYZ probably happened. And then recently we had some reports came in where we found products that were lipid sensitive, and those products could have been possible in that earlier report, and we didn't even consider that. So we went back and threw it in there as well as a potential possibility. There are some reports where we say we don't know what happened, but we can provide a lot of possibilities, and I find that often when we list those possibilities, they are things that were not considered at the local level. Now, we also allow the local level to input what they think happened and their suggestions. And sometimes that's perfectly right. Sometimes they're just spreading the word. We don't have to do an investigation. They're just helping other people to understand that that's a possibility.
Hi, I'm Melissa Berg. I'm actually a cardiac anesthesiologist. So I'm a member of the American Society of Anesthesia has a private message board where you can post anonymously if desired, patient incidents, and then get the hive mind of everything that has happened. I'm also a member of it's a private Facebook group of over like 50,000 physicians of all specialties. And again, you can post something like, hey, my cardiotomy pump exploded, any thoughts? But it's all kept under private. But the benefit of that is that I feel like you get a lot more input versus something like this where you have to subscribe and it's going to be a very closed group. Like anything I do within our patient safety organization at my hospital stays just within the walls of that hospital. It never gets any outside input.
I don't want to interrupt you. Did you have a question? No, I think this is a great point, and we're working in that direction. So
my question is, how do you not lose, like me posting a question and I get 50,000 physicians potentially can look at my question and put in their 2 cents, even if they're not an anesthesiologist, they might be some other, specialty.
These are
like
very
you
good
lose some of
points.
that, even though I understand what you're trying to do in terms of protecting it under the patient safety work product.
These are excellent points, and I think you have some good ones. Some of them I think are less powerful than others. So we are working, in fact, probably in the next week or two, we're going to roll out an online access to our system where people can receive training. Well, that'll be more 6 months down the road, but we're going to open our system online where eventually in the near future, we're going to allow moderated public comments to reports so that somebody has an idea that didn't come to us, it's totally valid. We're going to post that up there as an addition to that. I will say we have those of us who have been online occasionally in the past, at least as far as perfusion, people will post pictures or scenarios that they've encountered. They're not private groups, but I have found that you're almost living in the TikTok world, and maybe your experience is not the same, where people will post a large number of responses. That's the first thing that came to their mind, and quite often it's just not right. And in fact, sometimes couldn't be more wrong. So we definitely try to avoid that. Occasionally, what's the saying? A missed clock is right twice a day. So sometimes you do get good information, and I think that the other important point I want to make is that your PSO stays at your hospital, but does not have to be that way. We have over 100 member facilities across the country, and that information is de-identified before it's shared between facilities. But if an accident happens at hospital A, hospital B knows about it in 3 to 6 months, full analysis.
I'd probably also argue that I'm not sure about the HIPAA compliance of Facebook. Even with a private group, if you're posting any data there that is relevant to patients, that is you're in deep trouble. So I think I appreciate what you mean. However, you cannot put patient data there and then discuss it in a meaningful way. So there's a difference between getting the opinions of people and then discussing something in a more kind of case-centric, almost forensic,
formalized process.
Yeah, exactly.
Yeah.
My question was going to be in terms of, and this is slightly biased because, as you can tell by the accent, I'm English. Is there any way that the international community can see these reports? Because something that happens in the States may well occur elsewhere.
Mm-hmm.
And, it's always kind of shocks me that the answer is, oh yeah, we knew about that. I need to see it. So is there a way that we could gain access, or at least, the publications that we could see?
We are working on that. And the good part is that while we can't control the laws in other countries, if we send this information out of the country, if it gets smashed around in a washing machine and a lot of people see it and it comes back into the US, we can still say, hey, what happened there has never been published. You can't show a published case report where that happened. So we know that came from us and it can't be readmitted. So we're working on ways to do that, and hopefully in the next 6 months we'll have that available.
Thanks.
I have
Yes.
one. Most of your examples seem to be like equipment or product related. Is there anywhere to report staffing issues such as unsafe ratios or like maybe you have 5 ECMO machines at your hospital and you like to support 4 patients and have 1 backup and then they put that backup on? What does the perfusionist do in that situation?
So our only metric is we call these reports non-routine events. So for us, that definition is, if you want to report something, the only threshold is it's something. Actually, Greg, who was here earlier in the meeting, he coined that definition when he published on their local site-specific incident reporting system many years ago. But our threshold is, if it's something that was not normal and you don't want to see it happen again, you're welcome to report it. The only thing I would caution you is sometimes people report things that make them feel emotionally unsafe, or like it's an unsafe work environment because people are yelling at me or they don't want me to advance in my career. We are not equipped to handle those types of reports, but anything else we can take. Yeah.
So just one more question. I'm curious what defines that protection. Is it kind of like between a lawyer and their client, how they have the patient information privilege? What defines Orem, that privilege, that
So-
everything's protected?
Yeah, so we are a patient safety organization. We are listed with the U.S. Department of Health and Human Services. There's a process to become listed. Once you are a listed PSO, you can take you can conduct patient safety activities. These are all outlined in law by the Patient Safety and Quality Improvement Act of 2005. And so this has been a very slow, it's interesting because laws that tell you what you can't do get enacted very quickly, right? HIPAA was passed, and within 12 months, every hospital was doing mandatory training, every 6 months, right? But laws which are passed, which allow you to take advantage of opportunities, like pretty much everything we have here, are very slow to come, surprisingly, to come into being. So we're listed with the U.S. Department of Health and Human Services as a listed PSO. That permits us to engage in these patient safety activities, which is what you see there. The fines for breach are enforced by the Office of Civil Rights. And I felt like there was one other part to your question that I didn't answer, but the other part I would say is that if someone came, we don't house the data, we use a third party, and they have every security measure that's required to operate in the US, whether you're an accounting firm, a healthcare firm. So we've done a lot of vetting. That's Origami Risk. They're a worldwide company. If they came into our office, if the FBI came into the office with guns drawn, I could not provide them access to that information. I can log in, but that's the only thing I would do. After that, they would be required to get a subpoena.
Thank you.
Okay. Thank you. For respect of the other speakers.
Yes, absolutely. Let's get it out of here.
Yeah. I just want to remark before you go.
Yes.
We had a report like a few weeks ago, and the reporter mentioned that they had a problem. I can't remember what it was, but they could solve it because they had read different reports from the PSO,
In the past.
and so the effect is coming into motion. But Michael, thank you so much, and thank you for the great discussion.